All right, good morning. Thank you for having me. And thank you to Dr. Surik, the PI, who's here as well. I'm going to talk about laparoscopic versus open emergent ventral hernia repair. And this is actually an expanded analysis on a study we presented last year. This year, with vastly more patients, some better data from about 10 years of NSQIP data. Multiple recent studies have assessed the efficacy and safety of laparoscopic versus open ventral hernia repair and showed associated decreased morbidity, shorter length of stay. Excuse me. And with associated with laparoscopic ventral hernia repair. A couple of recent meta-analyses also show that laparoscopic ventral hernia repair is associated with decreased surgical site infection. And despite these studies, utilization still does remain low, especially as it lags behind other complex surgical procedures, namely, lap chole, things where laparoscopic repair has certainly taken the lead. We hypothesized that the utilization of laparoscopy for ventral hernia repair would be significantly lower in emergency cases, and relative to elective ventral hernia repair, emergent ventral hernia repair is associated with markedly increased rates of morbidity, which does leave the door open for possibly a lot of benefit if we more frequently utilize laparoscopy in these emergent cases. So the aim of our study was to evaluate the utilization of laparoscopic ventral hernia repair in emergency cases to assess the 30-day outcomes for patients undergoing laparoscopic versus open repair. So we used the NSQIP database, the years 2006 to 2015. Patients who underwent laparoscopic versus open emergency ventral hernia repair were compared first were found by CPT code, having undergone emergent umbilical, ventral, or incisional hernia repair, either primary or recurrent. And our primary outcomes were postoperative length of stay, 30-day morbidity, mortality, as reported in the NSQIP database. So this is a summary of the CPT codes we used. Again, open and laparoscopic, ventral, incisional, and umbilical hernia repair. A total of just over 13,000 patients, 8.6 underwent laparoscopic emergency ventral hernia repair, and 91.4% underwent open. The data did display a trend towards decreased utilization of laparoscopy in patients with more significant comorbidities, and we'll show a expanded analysis at the end to account for ASA score. This shows by year, starting with 2006, when 0 laparoscopic repairs were performed, with increasing utilization by year. And one nice thing here we do see, so this is, get back to that one second, but this is the utilization by ASA score. You see that, what's going on? You see that as ASA score approached 4 and 5, significantly decreased utilization. And then here is increasing utilization by year, depicted a little bit better here. You see about 50% increase in utilization as we go from 2009 to the most recent year available, 2015, which is nice to see. Can I go back?
Now she's still in trouble.
The slider works? Okay. So just to go through our results, starting with, thank you. Starting with the patient demographics. When we did this study initially, we only included 2 years of NSQIP data, because that was what was available for last year at our institution. There was basically no difference in the demographics, but now as we have 13,000 patients, everything seemingly is statistically significant, but this was accounted for largely when we separated by ASA score as well. You see age, BMI, ASA class, not great differences, 56 to 57 years, but with that sample size, it is statistically significant. And again, as we go through and we look at rates of dyspnea at rest, ascites, COPD, smoking, steroid use, all of these are more greater numbers in the open category, which is again why we did the subgroup analysis at the end. I'll show all of the data in a second, but it's a very busy slide, so just the summary of what we found. Operative time was significantly greater for laparoscopic repair. Laparoscopic repair is also associated with significantly decreased mean postoperative length. The way we define length of stay was postoperative length of stay, so from not the entire hospital course, but from the day of surgery to the day of discharge. It was associated with lower mortality, 1.2% versus 2.4%, decreased deep and superficial surgical site infection, decreased wound disruption, decreased respiratory complications of pneumonia, failure to wean from the ventilator for 48 hours, and also postoperative sepsis. So what's interesting is not all, when we had this analysis from last year, we were unable to find statistical significance with some of these values, but with the greater numbers now, we were able to find significant differences in mortality, surgical site infection, again, the wound complications, the respiratory complications. But when we look by ASA class, again, sometimes, especially with ASA 4 and 5, the numbers weren't, we didn't have the appropriate power to make statistically significant claims. What did help, though, was pooling ASA 1 to 3 together and removing 4 and 5, when in a lot of cases, the ASA 4 and 5 groups really accounted for the vast majority of complications. So it was nice to see when we were, and also almost virtually all of those patients who came in, with preoperative sepsis, they came in and accounted for a lot of the postoperative morbidity. So even when removing them, we did still see statistically significant decreases in superficial incisional site infection, deep incisional surgical site infection, wound disruption, pneumonia, and postoperative sepsis. What we didn't find, though, is decrease in mortality for ASA 1 to 3 patients, which we didn't expect when we started the subgroup analysis, but was interesting to see. So laparoscopic ventral hernia repair has been shown to offer patients quicker recovery, decreased rates of morbidity, and as we said earlier, despite the benefits and studies that show that it is a safe approach, even in the emergency setting, utilization does remain relatively low. This study displays that a patient undergoing laparoscopic emergency ventral hernia repair had decreased postoperative length of stay, decreased wound, respiratory, and infectious complications as captured by the database. And we think that increasing utilization may offer significant benefits. Limitations, again, as has been stated in other studies, limited by the limited that it is a retrospective study. Specifically here, the relatively small size of one cohort, it does limit our analysis a bit. Selection bias is obviously a huge problem for this type of case, but we did try to account for that to some degree with the subgroup analysis. A lot of the patients who came in with preoperative sepsis, or virtually all of them, were grouped into the ASA 4 or 5 categories, so that dropping them out did make the data a little bit more uniform on the demographic side. The database only tracks for 30-day outcomes, which if anything happened after that, obviously that's not included here, which is another limitation. But we do think the most important aspect of the study is to suggest that laparoscopic ventral hernia repair is an appropriate option in the correct, when the surgeon is comfortable, obviously. Any questions? Thank you.